So guys, let's finish up this tat on, or is it a tat though? Whatever it is, let's finish up this history taking tat. Let me call it tat, it's fine. So like I said, that this is might not be very helpful and relevant for doctors who are already medical officers and all of that, and also some interns. But it's very important for students. I have seen that students, they struggle with history taking because of the template that I'm talking about. They follow that template, and in the process of following that template, they don't ask the important things. They just follow that template. Like I said that for instance, as I explained yesterday, that if you've got a patient that is an obstetric patient, the entries that they expect there. That's why I even said, when I see a patient carrying that maternity booklet, I always flip through that booklet before they even speak to me. I make them to sit and I flip through that document. Like I said yesterday, when you're doing obstetrics, what they want from you when you write your history and how you present, they want you to say female, whatever age, 35-year-old, GWAT and PWAT, and alive. This thing of alive, I know in Pretoria they hate this thing of alive. They don't put it, but where I'm working, they put that alive thing there. So they want you to say GWAT, PWAT, and also say the weeks. How many weeks are they? Are they 36 weeks or 33 weeks? And was it by, and this 33 weeks, was it determined by early ultrasound or late ultrasound, or is it by dates? That's what you have to say there. Then that part is complete. And then the next thing that they want is the RVD. Pay attention to the fact that I've not said anything about the chief complaint here, why the patient came to the hospital. It's just the information that I get from the card. RVD, status, positive or negative, on treatment or not. And when you come here, RH, RPR, this is the information that you get from the booklet, not from the patient. And then from there, you begin now to ask them, okay, what is the problem? They tell you, okay, I've got this, that. I'm having abdominal pains, I'm having bending on maturation, I've got this, I've got that. And then you take your history and you follow the chief complaint and exhaust it. Make sure that you get a differential from that part. And then after that, you do your gynae history. That's why I was saying yesterday that if you've got an obstetric patient, they don't want to hear about the past medical history just yet. They want to know about, because it's a gynae patient and you are seeing a gynae patient and you are working in obs and gynae, so they want to know about the gynae history now. And then after that, they want to know about the obstetric history. So now you're going to dwell more on this. It's a G6, P5, A5. So the P5 is so you write the sex of the child, the gender, and when were they delivered, were there any problems, mode of delivery, were there any parental problems, things like that. You might even mention that patient had eclampsia on the third baby, how many scissors did they have, all those things. That's your obstetric history. Then your gynae history, LNMP, how many days a cycle, dysmenorrhea, history of menarche, history of contraception, things like that. And then you talk about past medical history. And a consultant who's working in obs and gynae, the minute once you do this and then you run to past medical history, they would be very mad at you. Once you run to past medical history and then you come later on and talk about these for them are golden. For them, they are golden because they are working in obs and gynae. That's why I was saying that history, the way you take history and the way you write your notes, it depends what kind of a patient are you seeing and where are you working. Then now you talk about the past medical histories. Okay, RVD, what regimen are they? Is it just mentioning me the TLD, is it TEE, whatever it is, CD4 count, the last CD4 count, the last viral load, other comorbidities if they are there. Talk about the surgical history, talk about social history, allergies, whatever, and and review of systems and all those things. But people hardly do that, but it's fine. Okay, so this is how you structure your history in an obstetric patient who's pregnant. But this is different for someone who is not pregnant, a gynae patient, in the sense that this doesn't become relevant if it's just a gynae patient. But this kind of a structure still remains, but this one falls off, and this one is not relevant, this one is not relevant. So with these kind of patients, you can track them. A female patient, 35-year-old, came in with complaining and then you get here, and then you're done. That's a patient who's not pregnant. Yeah. Now, what happens when you've got a pediatric patient? Pediatric patients, there's one thing that you need to understand. Okay, let's talk about a 3 months old female. 3 months old female. Female. So with this one, the entry there for pediatricians, the first thing that they want to know they want to know about the RVD exposure of this child. Is this child unexposed? Is this child exposed? Is RVD exposed or unexposed? And if they are RVD exposed, they want to know about the PCRs. What are they? The birth PCR, the PCR at 6 weeks. What were they positive? Were they negative? What is happening there? And this thing of RVD unexposed, you need, for you to write with confidence that the child is RVD exposed, you must have checked the documents. Here, word of mouth does not really help sometimes, because patient can be misleading, because there are still people who are still hiding. There are still mothers who are still hiding their statuses out there and all those things. So it's better if you check the chart, the road to immunization booklet, and write something that you have seen. If it's not there, you can say that it's not recorded or whatever. And then what they also want to know is the immunization status of the baby. Is it up to date or is it not up to date? And then now they want to know about the complaints, and then you write it like that. Make sure that you cover everything, you ask. And also another thing that they also like, pediatricians, they like you to say, this child, who brought this child to the hospital? Is it the mother? Is it the father? Is it a neighbor? Who, the relationship of the child with the person that has brought the child. Some people, they also like it to be there. So, and then once you're done with your chief complaint and your associated symptoms, now you get to your birth history. Talk about the birth history of the child. Was this child born at term? Mode of delivery? Was it at hospital? Things like that. Were there any problems? Was the child admitted after delivery? Was there anything wrong? And then from there, you talk about the immunization history. So the immunization history, you dwell now and say, okay, this child missed this. These are the vaccines that the child missed. These are the ones that the child got. And then from there, you do feeding history. In final year, there is no time to learn about history, because you need to learn the work. So you should, at final, you shouldn't be struggling taking history and doing all these kind of things, because it means you're gonna need to do a lot of catch up. So that's why I'm really helping with this, so that when you start your rotations, you know how to take history. And then birth history. So if you can see, this part is really specific for peds. It's very specific for peds. You don't find it in any other. In surgery, we don't talk about this. In internal medicine, we don't talk about this. In ops and gynae, we don't talk about this. It's very specific for for the kiddies. And then after that, you do your past medical history. Then you can talk about the RVD exposed, and you can still repeat it here, and also you can still talk about, because the thing is, when you say 3-month-old female came in with cough, vomiting, someone who's listening to you is gonna interrupt you. They'll say, what's the RVTs of this patient? Especially if you give them a picture of TB, they want to know, is this child exposed or unexposed, things like that, and they interrupt you. So, and then now you dwell now, okay, does the child have any congenital problems like congenital heart disease? Were they diagnosed with anything? Are they on any medications as yet, whatever in the past medical history? But the past medical history can also put the history of the mother there, the RVD status of the mother there, and then from there, yes, the issue of the family history, you can put it, but most of the times, yes, it's important for some conditions that you put the family history, especially in other things that I didn't mention. So also put that as well. But I wanted to give you the core of how you take a history, depending where you are. Then yes, you can do your surgical history, because there are kids that have done operations even at that age already. And then you can do your allergies, your social history, all those things, and all review of systems and all of that. So it's important that you remember a child that is less than 18 months, you need to talk about the RVD exposures there and the birth PCR. But the minute they are more than 18 months, they need to be done a VCT. So after 18 months, you cannot be talking really about, you can mention that, okay, the child is RVD exposed, but their VCT is negative. It's okay. Not an issue there. So that's for peds. It's very interesting if you look at how anesthetists take their history when they do a pre-op assessment. It's very, very, very different from so that's why I was saying, for them, the last meal becomes very important. Drug histories becomes very important. Their comorbidities, because it becomes very important. They also, the previous anesthetic exposure, were there problems, things like that. It becomes very important. Also becomes very important to assess if the patient is gonna have difficult incubation, and they also plan how they're gonna incubate, and what, like the airway, how are they gonna manage the airway basically of the patient. Does the patient need an LMA? Will the patient need an LMA? Will they intubate? But the way they take their history is very different from any other discipline. So as I was saying, taking history is specific to where you're working and what kind of patient you have. There is no one shoe fits all. I hope you guys get that. You can drop me a comment, like, and let me know. We can always go through anything that you are uncertain about, and if I've got the answers, I'll give it to you. Thank you so much.